A Schedule II opioid analgesic. Know the facts. Dangers of Demerol. This presentation contains information about how Demerol acts in the body, what are the signs of withdrawal, and knowing the risks. In the body, the route of administration is either orally or by injection. Orally is rarely given. An injection can be through intramuscular, subcutaneous, or intravenous. Demerol typically acts fast and wears off quickly, but that depends on two chemical compounds. The first chemical compound breaks down in 2 to 8 hours depending on the health of the patient. The second chemical compound can take another 15 to 30 hours for healthy adults, but can be 35 to 48 or more hours in patients with decreased kidney function. And that's where the danger is. The process of elimination of Demerol is it's metabolized by the liver, secreted by the kidneys, and exits of the body through urination. Even Pfizer notes that the key liver enzymes that convert its first form to a metabolite in its second form is then a neurotoxic chemical and can build up, especially in people with kidney problems. Signs of withdrawal: anxiety, restlessness, irritability, muscle cramps, watery eyes, runny nose, sweating and chills, yawning and insomnia all occur in the first 24 hours. Nausea, vomiting, abdominal cramps, diarrhea, loss of appetite, dilated pupils, goosebumps, elevated heart rate, high blood pressure, and strong cravings for Demerol is in the peak withdrawal period, day 2 to day 5. Depression, mood swings, difficulty concentrating, and in rare examples, paranoia and hallucination are some of the psychological symptoms. Other symptoms include dry mouth and low-grade fever. Knowing the risks. The overdose potential and potential for lethality is high because it is a strong opioid. Even a single large dose can be fatal and bring death accidentally or by misuse. This is because it slows breathing very quickly. Certain conditions make Demerol more dangerous. For example, if the patient has kidney problems or those taking MOAI inhibitors. Because of the narrow safety margins, even in medical settings, there is a move away from this treatment. In my scholarly journal, we learned that Woolery examines the clinical use of Demerol and highlights the concerns about its safety in clinical care settings. The article reveals how Demerol was historically popular as an analgesic, but has fallen out of favor due to its unique pharmacological properties and increased awareness about its risks. It explains that it acts as an opioid analgesic, but is then metabolized into another form, a compound with neurologic effects, which accumulates, especially in patients with renal impairments. Woolery emphasizes that the half-life is such significantly longer of the second compound that it can lead to central nervous system side effects such as tremors, agitation, irritability, convulsions, and in severe cases, seizures. The author points out that these safety concerns have prompted many hospitals and practitioners to reconsider or restrict Demerol's use. The article concludes that this drug's risks often outweigh its benefits, especially given the availability of safer alternative opioids today. Woolery recommends limiting Demerol to very specific short-term indications, such as brief use for post-operative shivering and avoiding it entirely for chronic pain and the elderly and those with kidney problems. My references are included here. Why I chose Demerol for my topic. The Schedule II opioid analgesic is often given even to children during oral surgeries. It's been around a long time, and it was designed as a synthetic alternative to morphine originally. But it has a powerful addictive effect. My first husband was given Demerol during and after a reconstructive surgery on his arm that was mangled in a farm conveyor belt system. Doctors doled out pills even a year after surgery without consideration of its effects. I want to thank you. My name is Keara Larney, and I am a student with the counseling program at Lindsey University. This presentation was produced for my course, Theories of Addictions in Pharmacology, under the direction of Dr. Patrick Murphy.